I have a question that some videos in YouTube has running about the use of two patients could be ventilated by one machine. I have a lot of concerns about this technique. And people say that in situations of a lot of patients to be ventilated, this strategy could be used. What do you think about this? I'm afraid to use one ventilator, one machine for two patients.
Okay, I'm Dr. Bindu. So you can hear me, right?
Yes,
yeah.
Yes.
I noticed that there are some papers published previously about the using one ventilator for two patients or even more. I even saw the video in the
Maybe we can hear another one of the experts, or maybe another question.
Maybe another question. But
Flávia, I think that this question is very important, Flávia.
No,
I would like to know about it.
Certainly it is, but some of the other experts can answer, not Dr. Bindu.
Of course,
that's what I said.
Of course, yeah.
Yeah, I'm Youzhong An. Yeah, so but maybe we will we do but as I know that in Wuhan, in China, we use the ventilator only for single patients. It's not for two patients. It's only for single patient. But I want to hear what's the evaluation of the Bindu, the Dubin. I don't think it's a good idea, the one ventilator for two patients and even more. So you couldn't observe what's the real the response of the patients. So that's you couldn't adjust the parameters for the ventilators. But for me, moment we didn't might this kind of problems. So actually in Wuhan we have license. I think that in the same times, and we have license 1,000 ventilator one for same days. So it's not a big problem now in China. Yeah, but how about thinking of the Dubin, the Bindu?
I think he is disconnected. He's not connected.
Yeah.
I think we lost him.
Yeah.
Ele respondeu na primeira frase. I think that's a good idea.
Maybe I can. May I ask another question to Professor Youzhong? Now things are going much nicer, or at least we heard that in China things are under control. Can you talk a little bit about that? Because as we see in the WHO register, the new cases are very few. So how's it going? And if it's really better, what do you believe makes it become better?
Yeah, it's a good question. So we do pay attention to the second outbreak that, but at the moment we did much better than the January. So I think that we have some difference experience compared to the European countries and the United States. So because that we have the full centralizations. And at the very beginning, the outbreak in Wuhan is much like now in Italy, Spain, and the United States. But after that, so the government send a lot of so healthcare workers to the Wuhan, but it's not the only thing that's very important. But the very important thing is the early testing the patients, early diagnosis the patients, because that when I came to Wuhan, it's about 8 weeks ago, and we found that it's a totally loss of the control, and a lot of patients and the local healthcare workers are exhausted, and at that times, and we are worried about how many patients will come and how many ICU beds will need. And then, so we use the clinical diagnosis, not only the PCR, but also, you know, the the CAT scan, the chest X-ray, and even some you know, the academic histories for screening the patients. And after that, we centralize all of the patients as possible to several shelters. The big shelters, each of the shelter could accommodate nearly 1,000 of the patients. And then when all of the patients that's tested or diagnosed and quarantined in the shelter, and we could know how many patients, and we give them the triage, and how many mild patients, how many severe patients, and how many critical ill patients. And then we try our best to, you know, that to give the oxygen therapy and the ventilation. So, and even several hundreds were intubated and use the mechanical ventilation. So moment we discharge the patients by 2 times of the PCR negative. And even though there are still some patients, a few of the patients is recurrent. So it's maybe the PCR positive again. So that's a big problem. So we pay more attention to if this kind of the patients, if the PCR positive again and have the contagious, the infectable or even the worst condition. And then now we pay attention to that. So.
Professor, the patients are who begins positive again in PCR you believe they are reinfected, or it's a limitation of the method of the diagnosis? The PCR is not so sensitive. What do you think about this?
So it's a good question. So at the very beginning, so we use only the PCR. It's, you know, that's the false negative and the false positive even so. And the accuracy at a very early times is only maybe 30–40%, the accuracy. So, and then we try to use some clinical diagnosis. It's just as I mentioned, that not only the PCR, but also the CAT scan, the chest X-ray, and the very important is we need to know the, you know, the academic histories, what's the contact, what's who the patients contact before, and if there are any patients he or she contact.
So are you saying?
Pardon? Dr. Machado, huh? Or Dr. Dubin is here? Is again here again?
I don't think so. Maybe he's offline.
Uh-huh.
Oh,
Hello?
Dr. Dubin.
Ah, he's back.
Yeah.
Sorry for that. So what is the question? Still one ventilator for many patients, right?
Yeah.
Really want to know that the answer.
I want to know how did you use that?
No. I am not aware of any single case that managed by, you know, there's no patients to be ventilated or multiple patients ventilated with one ventilator. This did not happen here in Wuhan. But however, so you can hear me, right?
Yes.
Yeah. So, however, I should say that the ventilating two patients with one ventilator requires that the patients will be of the same size and the lung mechanic and similar lung mechanics. So, which might be very difficult. And you have
Thank
no
you,
way.
Professor. Yeah.
Sure. You have no way to monitor how large and what is the tidal volume for each individual patient. So I don't think it's unless you have very similar patients.
Okay.
Can I come back to my question that Professor Youzhong was answering, because I'm not sure I understood the answer. Are you saying that you believe 20% of the patients that have a clinical diagnosis of COVID are PCR negative, and you're treating them as false negatives and isolating them as if they were positive? Is that what you said?
So for that of candidate patients, and so we at first very early, and we quarantine of them and to test again and again, and to find if we have at least 2 or 3 times it's a negative. So and maybe and even we referred to the chest CAT scan. So and if no symptoms and no CAT scan changes, and so we didn't find any pneumonia, and even they have no symptoms, symptomatic, and the PCR is still negative, and so we diagnosed they are not COVID-19. And so I think in the shelter, it's maybe some people is false positive, even in the hospital, and there are a few of the cases. It's the final diagnosis is not the COVID-19, but it's not too many. But how about the Dubin's opinion?
I did not have the I did not get the question. What is the question?
Dubin, we have a problem here. For instance, now at this time in the epidemic, if the patient is coming with a PCR that it's negative, we are taking him out of isolation with a single PCR that it's negative.
Mm-hmm.
So my question is, even if it's the clinical picture, it's suggestive of COVID-19, if the PCR is negative, we are taking them out of the isolation. So the question is, do you think this is safe? Are you seeing too much false negative patients that after the first PCR became positive?
Well, Flavia, I would say this is not an appropriate approach, because as Dr. An said, that there are many patients who had initially who had negative PCR test, but however, eventually turned out to be positive. I mean, according to the repeated PCR test. I even know a case that in my hospital back in Beijing, who had repeated about 5 or 6 times about PCR test.
Yes.
I mean, all the previous PCR tests were negative until the last one, because the clinicians suspected that even though with the negative PCR test, they suspected this is a true case of COVID-19. So I have no perfect explanation for the false negative results with regards to the PCR test. I think, among all the possible explanations, I think there are several, such as the different manufacturers of the test kit, about the sampling technique. I do believe their sampling technique might play an important role.
Yes, I agree.
And I'm not quite sure if the viral shedding will persist day after day, or it will, fluctuate. That the viral shedding will occurs periodically. I'm not quite sure about the last explanation, but anyway, this happened not in minority of the cases. So I would say that only do not isolate patients based on only one negative PCR test might be inappropriate.
Thank
Flavia.
you. Thank you. Thank you. I understood quite well.
Could you comment on, can I ask one question?
Yeah, please.
Could you two professors please comment on the use of hydroxychloroquine or the use of antivirals in China? Did you use in a lot of patients? Did you use only in the more severe ones? Or can you comment, please?
老安，你有什么说法吗？Dr.
So you know that in our house, so in Zhongfa, in Tongji hospitals, we use some chloroquine. Chloroquine. So, but I don't think that's a significant difference between the control. I don't know the control. So I know the control because the hydrochloroquine and the normal quinine. So, but no significant difference up to now. But not so many cases. I think that's maybe 20 or 20 more. But
yeah, I agree. I agree with Dr. An in saying that actually in Wuhan, there are multiple antivirals has been tested clinically, but not in clinical trial.
No.
So I don't believe we have solid data or convincing data supporting or against one over the other. But anyway, according to the the information that I have right now, there is no effective antiviral agent against the COVID-19, against the SARS-CoV-2.
And they even have some the side effects for the for the eye and for the liver function.
Yeah. And I think there is a question raised by Isadora about the nasal, high flow nasal cannula. It has been used very often here in Wuhan and in other cities in Hubei province. However, according to my own judgment, the failure rate might be high, either due to persistent hypoxemia at rest or exertional, or it could be a persistent dyspnea or respiratory distress, even on the high flow nasal cannula. So I will not suggest a trial of high flow nasal cannula for longer than 1 or 2 days.
Professors, I have a question about the time of evolution from the first symptoms in the patient until he needs mechanical ventilation. There is a time, average time in the cases who begins more severe that you can notice.
The timeline, the time
course. Yes, time course.
Well, the presenting signs and symptoms of COVID-19 usually starts with the fever, dry
Yes.
cough.
Dry cough.
And however, in some of the patients will develop, diarrhea, nausea, and vomiting instead of the respiratory symptoms and signs.
Okay.
But that's minority. And however, they are doing okay. Whatever the presenting symptoms, they seems okay during the first week. So it is very common for these patients at the end of the first week, they will develop shortness of breath or dyspnea, respiratory distress, and hypoxemia. So it's about 5 to 7 days, after disease onset, they will have signs of respiratory failure. And in Wuhan, they will admit it to the hospital. Whenever they had the respiratory failure, and then on day 10 or 14 to 14, day 14, they will admit it to the ICU.
Yes.
If the respiratory failure is severe enough to be admitted to the ICU, they will admit it to the ICU, usually from day 10 to day 14. And if he or she was intubated with the invasive mechanical ventilation, if for the survivors, the duration of mechanical ventilation usually, I think, 2 to 3 weeks.
Okay.
Yeah.
You
never think about winning the patient within 1 week. Never.
Okay. Thank you.
Sure.
I'd like to ask about the ventilation beginning. I have heard some relates about using the oxygen cannula and the patient benefit with that. And so we can postpone, and some patients even don't need ventilation. But is there a trigger, a moment trigger, or a symptom trigger to get patients on ventilation?
So the indication for mechanical ventilation.
Yes.
Is your question, sir?
Yes. The beginning of
So how about
mechanical ventilation, please.
Dr. An?
Yeah.
老安，你有什么 comment?
So I think that in my opinions, we need to observe and monitor not only the SpO2, but also the efforts of the patient efforts. So if maybe we use the high flow nasal cannula and so another, the oxygen therapy, and but if the patient's breath is a very severe short of breath, and so you could watch the patients have the very big effort to breathe, and even that they can't maintain the SpO2 above maybe 90 or 92 or 93. So, and I think that the intubation is a only choice for this kind of patients. But that in Wuhan, we haven't enough experienced staff to ventilate the patients. So, and as you mentioned that as a symptomatic trigger is very often. So, and for me, and we sedated the patient and paralyzed the patient at the very beginning. And then, so to to decrease the the patient ventilator fighting, and we try to keep the transpulmonary pressure is less than 20, even 16. But for me, I don't care the plateau pressure, but I focused on the transpulmonary pressure. The driving pressure. So and so we need to keep the driving pressure in the limit, within the limit. So it's my opinion. How about Dubin?
With regards to the timing or indication for mechanical ventilation, I would say the first is hypoxemia. Well, there are some patients who had what we call the silent hypoxemia, which means whenever you saw the patient, he or she was doing quite okay. There's no signs of the respiratory distress. There's no signs of the shortness of breath or dyspnea. But however, when you put the oximeter on the patient, it could reach as low as 70%. I mean, so which means I would advise that to have the SpO2 in every patient, whatever it turns out to be. What is the the whether he is in shortness of breath or not, do test SpO2. And so this is the one of the indication that I would say. The second one is the respiratory distress or significant inspiratory effort, as mentioned by Dr. An. So, for example, in patients who were ventilated with NIV, non-invasive mechanical ventilation, a tidal volume higher than, let's say, 800, 900, or even 1,000 mils suggests failure, and you should consider immediate intubation, endotracheal intubation. So I think these are the two indications that, in my mind, indications for mechanical ventilation.
Agree. Yeah, it's important. As Professor Du said that. So it's very important because maybe Dr. Dubin, it's early patients or the late patients. You mean that? I think that for the summer, because so when I came to Wuhan, it's not so many very early patients now, and I as I mentioned that. So, and the patients cannot respond as a short of the breath, as a respiratory distress. Even the heart rate is, like we talked before, it's slow, and only the heart rate may be the 70 and even 60 and 80. So that's not a good thing, because for the oximetry is only maybe 8%, even 70% and 80%. So the slow heart rate and the slow breath rate is not a good thing. It means that the patients have a very severe damage for their cardiac function and the breath function. Do you agree that, Dubin?
Well, I'm not quite sure about the you're talking about how early or how late these patients are. I do believe that majority of patients in Wuhan are ventilated quite late, at late stage.
Yes.
And the same, I think you have the same experience.
Yes. And so you notice that the EKG is not significant abnormal, and even the troponin is not so high as the typical
leave the question to the audience.
Yeah.
Leave the question to the other experts.
Mm-hmm.
Okay.
Okay.
May I suggest?
I have a question. Can you hear me?
Yeah.
Sure.
Yeah.
Please.
I have a question about the patients that develop shock, circulatory shock in these situations. Could you synthesize the best approach for these patients in, I know, I mean, vasopressors, I'm sure is not adrenaline. Fluids, restrictive therapy, and for monitoring the hemodynamic in these patients, echo, pulse pressure variation. How do you manage these patients when they develop shock?
Mm-hmm. So it's a question about circulatory shock.
Yeah.
Circulatory shock is common in ICU patients. I mean, ICU patients rather than, the patients in general wards. With a prevalence of about 20 or even 20% or even higher. And just as Dr. An mentioned minutes ago, that a higher proportion of patients will have evidence of cardiac injury, as suggested by elevated biomarkers of cardiac injury, such as the troponin I level, or the hypersensitive cardiac troponin I, both of them. And with regards to circulatory shock, I would say that septic shock is not so common. It's not so common until at the late stage, whenever the patient had secondary infection, pneumonia, or bloodstream infection. That might be septic shock. But for the other patients, I would say you should be aware of the cardiac function of the cardiogenic shock rather than vasodilatory. And so with regards to vasopressors, yes, the noradrenalines has been used, although in some of the cases, the doctors might administer the inotropes, such as dobutamine, dopamine, and sometimes adrenaline. Echo has been used widely, especially in February, when we are no longer short of medical devices, and in some cases, the doctors, the clinicians did observe a few patients with so-called acute pulmonology, which might be secondary to severe hypercapnia with PaCO2 up to 90 or even over 100.
There are some characteristics for these COVID-19 patients, and so the cardiac function injury is very often. I think that if we use the echo, and we could find that it's not congestive heart failure, but you know that the left ventricle is usually normal and even so smaller than the normal, but the core pulmonary, like the right ventricle, is sometimes is enlarged. So and a mild hypertension for pulmonary artery, and so that's I think that, like the Professor Dubin said, that even we have the hypercapnia, the PaCO2 is very high. And if this kind of phenomenon, we observe that, and we think that the pulmonary capillary was damaged very, very severe, and no gas exchange, and even the blood from the right heart to the left heart was damaged. So it's a problem. So, and that means the right heart is, you know, it's a hyperdynamic, but the left heart, the left ventricle, have not enough blood to pump to the body.
This should be a case for the butamine.
Even sometimes we use sometimes the dobutamine and even levosimendan.
Levosimendan?
Yeah.
Did you have a good experience with the levosimendan?
Yeah, we have two cases. For me, we have two cases to use that, and it's a for these two patients, we think this have effect. Okay. But yeah, but it's only two cases.
Okay.
I would like to know about the dimmer. Did you use the anticoagulants for this patient?
Anticoagulation, such as heparin or low molecular weight heparin, right? Well, I know that some of my colleagues here will promote or will, use the anticoagulation in patients. But however, out of the, prophylaxis, out of the context of the, DVT prophylaxis, if we are talking about DVT prophylaxis, my answer will be yes for majority of the patients. But however, if we're talking about anticoagulation in patients COVID-19, I don't think so. I don't think we have much, good experience or good results from that. No.
Okay, and about PEEP, which is your experience about PEEP and the adjustment about PEEP?
About PEEP.
And also, if I can add on recruitment maneuvers,
okay.
and also on prone position.
Okay,
on
sure.
overview of mechanical ventilation, please. Thank you.
Okay. For mechanical ventilation, I noticed that David Cimolo from Italy said that COVID-19 is not like ARDS, and I agree with him, because it's very rare for you to see a chest X-ray or chest CT scan to have the consolidation in the dependent lung. And with regards to ventilatory strategy, I would say low tidal volume, ventilation has been widely used, as you may imagine. But however, the PEEP setting might be very interesting, because whenever you increase the PEEP, especially during the initial stage, shortly after endotracheal intubation, whenever you increase the PEEP or you perform the recruitment maneuver, the response might be very good. And However, it might be accompanied or associated with a much higher increase in plateau pressure. For example, I had one patient that I decreased the PEEP level from 10 to 5. And what I observed is that the plateau pressure decreased from 30 something to 20, decreased by 10 or more than 10 centimeters of pressure of water. So which means even a low PEEP level as 10 might increase the risk of over distension. So which means that majority of the patients might have, a PEEP level between 5 and 10 in order to avoid the alveoli over distension. And propositioning works in about 70 to 80% of the patients. So I would highly recommend propositioning on top of the recruitment maneuver or higher PEEP in those patients who had the poor arterial oxygenation whenever on mechanical ventilation.
Even some patients not very critical ill and not ventilated, and we could let them to have the prompt position, no?
Yes, exactly. And even for patients who are on an IV or high flow nasal cannula, I know that not a small number of patients will be put on the prompt positioning by their treating physicians with very good response.
Yes.
And about the use of nitric oxide, did you have an experience in these patients?
Nitric oxide is not approved by China FDA. So it's not used in China, in mainland China.
Okay, thank you.
Can I ask you something about inflammatory cytokine storm on these patients? There are a lot of suggestions from several countries saying that we could use, for instance, corticosteroids or anti-interleukin-6 blockers like monoclonal antibodies. Did you have any experience on that? Could you comment?
Well, so you can hear me? Can you hear me?
Yeah.
Yes.
Yeah.
Okay. Corticosteroids is a highly controversial issue or topic in viral pneumonia. So you can imagine that there are a lot of different opinions. That I do believe some of my colleagues, majority of them are chest physicians, pulmonologists. They would favor the use of the corticosteroids. And they will always think, escalating the dose of corticosteroids whenever the patient deteriorated. And there is another group of physicians, doctors, who do not believe that the corticosteroids will benefit the patient. And my personal impression is that the long-term high-dose corticosteroids will definitely do more harm than benefit and prolong the duration of viral shedding in worsening the lymphocytopenia and might leading to more, higher risk of the secondary infection. So I'll never use long-term higher dose of corticosteroids. However, I'm not quite sure about the efficacy or safety of the short-term use of corticosteroids. Let's say corticosteroids of no longer than 5 days. And with a dose of the methylprednisolone of about 80 milligrams per day. So I'm not quite sure about that, but anyway, a higher dose, let's say 240 or 160. I don't believe so. I don't believe it will, you know. But what I'm not quite sure also is that whenever the patient had resolving, you know, infection, pulmonary infection, either due to the virus or due to some, you know, bacteria, and there is evidence of organizing pneumonia according to the CT scan of fibrosis. You might think about the corticosteroids in the absence of activated infection, active infection. But however, that will be the late stage stuff rather than early stage. Do I make it clear? I mean, with the corticosteroids.
Yes.
And
Yes.
a few words about the cytokine storm. Frankly speaking, I don't know what is the definition of cytokine storm in the context of sepsis or severe infection. And I know the so-called cytokine storm might differ in different clinical scenarios. And I don't believe the concept of treating patients with COVID-19 with L6 monoclonal antibody is I don't think is a correct way, because L6 is not the key. It's not the most important cytokines as far as we know. So I think it's based on wrong principle, wrong concept. I will never use the L6 monoclonal antibody.
Yes, if we use the L6 monoclonal antibodies, and we could find that the L6 level in the serum will be much higher than before, than we use the monoclonal antibody before. So, and even so the cytokine level in COVID-19 patients is not as high as some like the bacteremia and so the sepsis patient. So I don't think the cytokine storm, like Dr. Du said, is the key roles in the COVID-19. And for the corticosteroid, and we need to monitor the patient's response. If the patient's chest X-ray or CAT scan developed very quickly, and maybe we try to use for several days, only a couple of days, maybe 2 or 5 days, like inside, and we observe what's the change after we use the corticosteroid, like the methylprednisolone, that's a 1 or 2 milligram per kilo. It's not a big dose. So you know that in the SARS in the 2003, we use a long time and the high dose corticosteroid, but they are not so good and a lot of side effect for this kind of patients, for the SARS patients.
In patients that develop acute renal injury, what's the time to start renal therapy, substitution renal therapy? And did you use continuous or intermittent renal replacement therapy?
Well, about 20 something, I mean, 20%, around 20% of patients had a acute kidney injury, very severe ones, requiring the hemodialysis. Both intermittent and continuous has been used here. The major difference due to the difference in human resources. So if you don't have the enough human power, you may consider the intermittent, as what happened in the hospital, which I visited regularly during the past 3 days. They will offer an 8-hour daily, 8-hour session of the renal replacement therapy for every patient who require the hemodialysis. But however, in other hospitals, they will consider continuous renal replacement therapy whenever they have enough human power, enough nurses.
It's primarily for some ECMO patients. It's continuous.
Yeah.
Continue.
Professor, what do you think about the prone position in ventilation? Is it useful in these cases, or it's not established?
Well, although there has been no paper published yet, I just mentioned that our personal experience was prone positioning in patients requiring invasive mechanical ventilation, in patients with non-invasive mechanical ventilation, and even in some patients treated with the high flow nasal cannula. Our experience are very good. And I have talked with some doctors from Italy, and they had the same, observations, the same results, that prone positioning will be a very good, measures to improve arterial oxygenation. So I would say it is the priority whenever you have difficulty ventilating the patients. You will always think about this.
Okay, thank you.
More questions?
Oh, and about the sedations, which drugs did you use?
Well, how about Dr. An?
Yeah.
Sedation.
Yeah, I know that. So I think that we use, as we usually use, that the morphine and some like the fentanyl and the 这边舒芬怎么说来着？苏米fentanyl. I don't know the exact word, the pronunciation. So, and we use the propofol and the midazolam, and so that as we usually use that. So we keep the patients as a RAS score. RAS score is a -4 or even 5.
Hello, Professor Dubin. Nice to meet you, Professor Youzhong.
Dr.
Hello. I would like to ask you a question, and then I would like to make a comment. So something that we are very concerned here is obviously the transmission of the disease to the caregivers. I know that in China you had lots of contamination, as in all the countries. Did you get, let's say, a good perception? I know it's very difficult to have a conclusion, but if you really contamination from the exhalation valve of ventilators or from non-invasive ventilation devices, they were really an issue, or you could not have any conclusion about this?
So,
for instance, just to make a very specific question, there is a big issue here. If we, some people to do economy, to not waste too much money, they use, let's say, not EPA filters in the exhalation valve. They use just HMI, heated humidifier. So do you have any hint from this?
Yes, so we ventilate several hundred patients in Wuhan, and we don't have any cases of contaminants, especially for healthcare workers. So I don't think the negative pressure room is a word is essential. And for us, it's most of the hospital don't have enough negative pressure ward. So, and we use but we keep every ward, they have the windows, and even we use some, the regular fans to make some wind from the indoor to the outdoor, and no patients and the doctor and the nurses were infected by use of the ventilator.
Okay. Good to know.
Mm-hmm.
And sorry, people, I was disconnected. Have you already discussed the use of FF2 masks and N95 for more than a single use? How you are doing this there? Are you reutilizing them, reusing them?
So for the for the medical staff to work in the ward, and we do use the N95. So, but if we leave the ward, even in the hospital, and maybe we only use the surgical mask, the face mask.
But
Flavia,
you use it for it's sorry.
Never think about reuse.
Or reuse. So sorry.
Reuse is not a good idea.
No.
I would say. I would say that, in my opinion, the at the current stage, most of the healthcare workers in Wuhan are overprotected because unlike the recommendations from WHO, and healthcare workers taking care of the patients with COVID-19 will usually have a cap, a N95 face mask, plus or minus a surgical mask, and a coverall, plus or minus a long sleeve gown, and a boot, and double glowing. So But my personal impression is that the N95 face mask is the most important one, and hand washing is the second most important issue, and nothing else.
Yes, but do you use them for, the problem here, Bindu, is that people outside hospitals, they bought a lot of masks. I'm aware about enterprise that bought more than 100,000 N95 masks for their employees. So they're running out of these in Brazil. So the problem of reuse, it's not an economical problem, it's a supply problem. So you didn't have any supply problem?
No, I mean, we did have the supply, a shortage of PPE supply in late January and early February, but not anymore.
And even
So-
on that supply problem, you did not run out of N95.
Well, we do have some problem. I mean, in late January, so we don't have enough N95 face mask at that time, and we will consider always put a surgical face mask on top of the the whatever N90 or whatever face mask on top of that.
But you did not reuse them even then.
No.
Yeah, this is one of the biggest issues in Brazil. We will run out of N95. We don't reuse them, in my opinion.
Sorry, Flavia, what did you said? Did you say that you reuse or you don't?
We reuse it. We reuse it for as long as it's okay microscopically, or up to 7 days.
Wow, that's very dangerous.
We developed a technique to put them in sacks, in paper sacks, and a technique to put them again. And we are afraid that if you use it as a single use of a shift, a single day use, we might run out of them in some ways.
Few days.
Yeah.
And
so,
then
this is the biggest issue now. And I'm glad to know that you are not using all these lunar caps or this complicated things. As you said, I believe it's very simple. It's just a 30 grams cap and investment. But I agree that the mask is important, at least for patients in mechanical ventilation.
May I ask Professors Bindu and An, what's your the tracheal intubation? We know it's very a procedure that have a generation of droplets and most dangerous for the healthcare professional. Do you have any tips for the emergency and intensive care doctors to perform endotracheal intubation and in COVID-19 patients?
So, any tips, any suggestion for protection during endotracheal intubation, right?
Yes.
Yes.
And well, I would say that initially we don't have the positive pressure stuff whenever we intubated patients. And I have the experience of intubate patients with only googles, no face shield, no positive, pressure stuff. And I think it's okay whenever you heavily sedated and paralyze the patient, I think it's okay. But it happens. Right now, they have enough stuff, those stuff, but it's fine. So.
Okay, thank you.
Mm-hmm. Yeah, I have a very strong feeling that, but for instance, if you do an intubation and you are using just the N95, you just throw out after the procedure, right?
The N95.
Yes.
Well, yes. So, Dr. Amato, I don't think I got your point. I didn't get your point.
Because there is lots of people here in Brazil that they do a dangerous procedure and then they pack the N95 for a few days, reusing them. This is for me the most dangerous thing, because the mask is absolutely contaminated by droplets, and then we are putting in the bag, picking it up with hands and using it again. So I think this should be avoided by all means.
Oh, well, I agree. I agree.
Yeah.
But whenever you are running out of the N95 face mask, it might be tough.
But to win, it's not only the N95, and we need the face shield, no? Both the face shield and the N95.
You mean the endotracheal intubation?
Yeah, endotracheal intubation. Yeah.
Whenever you have the I don't know how to call it, but anyway, if you have the positive pressure stuff, there's no need for the face shield anymore.
Yeah, but if you haven't that, and you maybe use the face shield and both the face shield and the N95, no?
Well, it's okay.
Yeah.
It's okay. I once intubated patients with only Googles.
Mm-hmm.
Might be okay.
Yeah, actually, the face shield will protect a little bit at the N95, because although I agree with Marcelo that this is not the ideal world, it will be much worse not having any 95 in 2 or 3 weeks. So the rationale for reusing them, it's only the shortage. Nobody's saying that this is the best way to go. I believe that when the industry in Brazil start to producing them and the government allow selling them only to hospitals, we might stop reusing them, but not until it's not accomplished.
Yeah, but
fully understand.
I fully agree, Flavia. But I think a very, very, very easy tip is to use the N95 and a surgical mask on top of it if you're doing a procedure, because then you remove the surgical mask and the N95 is not so contaminated. It's very easy, but I realize that people is not doing this, and I think we should pay more attention to this.
Yes, for procedures, I agree, because if you're intubating, we are using face shields for intubation, so it's less contaminated. But I agree with you, but not as a routine. Our agency, our sanitary agency, they just they just release another recommendations, and they are not recommending the use of a surgical mask over the N95 as a routine. But for procedures, I agree. It's a good thing.
Yeah.
I have a comment regarding this. In my hospital in Jeddah, Saudi Arabia, we are using intubation team. So there's a lot of sets for intubation with everything is needed. It's mandatory there to use the video laryngoscope that makes the things easier. You not to need to put your face over the mouth of the patient, and fully PPE. the team is led by one intensive care doctor, experienced, or anesthesia doctor. In any case that the intubation should be intubated by the most experienced one to reduce the time and make things faster. All the PPE should be thrown as soon as you finish any procedure, cannot be reused. But we live there in a different situation. After the MERS-CoV, that any patient that received the diagnosis, most of them were dying. We could see that really that what makes the difference is once any patient arrived to the hospital, all of them was isolated in negative pressure rooms or HEPA filters room. And then once the patient is negative for testing, and the testing was not ELISA, was PCR. Once negative, the patient was released from the isolation, and even repeated many times the test. If the patient was not improving, repeated again. This made difference because all the patients were dying a lot, and the healthcare professionals, mainly in the ERs, in the emergency rooms, were dying. And after all, what really made the difference was isolation, contact precautions, airborne precautions, and this was what that really changed the course for this. And the MERS-CoV, there's a difference compared to the novel corona as 35% mortality. So it's very, very different situation. But the difference also was so not effective as the new one. Anyway, it's PPE, hand washing, and not to reuse anything. Anything was dispensed in the same time.
Well, thanks.
Can I make a question to you both, Dr. Dubin and Youzhong? We have heard that, and we read also that, and sorry, because I know that you have been talking also during this presentation earlier, that some physicians are using steroids and some are not. They reported a reasonably good experience reported in JAMA. I have seen a few cases in which the patient was very inflammatory with signals of, let's say, ground glass opacities, which is, for us as a pneumologist, it's a signal that you must have some alveolar inflammation and bronchiolitis. These patients, they seem to develop bronchiolitis after the big proliferation phase of the virus. And in my mind, this is very similar to what the typical pneumologist call bronchiolitis obliterans, because it starts with ground glass and then evolves to some consolidations that they look of some airways. And then I have seen some patients in which after having this bronchiolitis, diffuse ground glass opacities, a big inflammatory phase with PCR very high, D-dimer very high, we give small doses of steroids, and then the inflammation fades away. And then I have seen that in 5 days, for instance, the infiltrate is gone, and then with a decrease in the inflammatory markers. The fear we have is that, okay, after 5 days or 10 days, we may have a rebound of viral proliferation or some rebound of even the inflammation. Have you seen any of these, or you never experienced this?
Dr. An?
I think that's yeah, Dubin, go ahead. Go ahead. 你说啊？你说吧，这块儿。
Okay.
我觉得刚才
I think I have the same experience, Marcelo. There are some patients who initially showed very good response to corticosteroids, and then whenever you stop, they will rebound. And some of the pulmonologists will reuse the use the steroids again, and they will continue. Do not stop anyway. They will taper the dose.
Yes.
And so, as I mentioned, I don't think it's a good idea. I have seen patients who have been on steroids for more than 2 months. And it seems to me that these patients, not everyone, but these patients, it's very common for these patients who remain positive for very shining for quite a long time, even after 30 days. So I will never consider use the for such a long time. You know.
Okay. Okay. But you taper the dose after 1 week?
I will not. I will not. I will never use the steroids for longer than 5 days.
Okay.
Yeah, I agree.
Understand.
Yeah, I think that we had the experimental, like the therapies for maybe 3 or 5 days for corticosteroid.
Excellent point. Thank you.
And if there are some rebound, I don't know, in Brazil, and you use the convulsing plasma for the patients.
No, they don't have the enough
They
patients.
don't have, not yet.
Not yet.
Not yet.
Convalescent.
Convalescent, yeah.
Doctors, excuse me.
Your microphone.
From Mindray. Yes, we have a question here all the time is appearing about the parameters in the mechanical ventilation. So the behavior of coronavirus we know is a little bit different, and I would like to share this question with you, Dr. Marcelo, about the parameters in the mechanical ventilation. This is the first question, and then another question here that appears about the adaptive ventilation modes. Unfortunately, some parts of our country, the doctors are not so familiar for ventilators, also the physical therapy. So what about the parameters and the adaptive ventilation modes, like ASV, ANV, volume support, something like that for these patients?
Well, with regards to mechanical ventilation, I will say that it makes a huge difference with early versus late intubation. You can imagine that in Wuhan, most of the patients were ventilated quite late in their, duration, in their time course of illness, which means whenever intubated patients, put them on the ventilator, you always have FiO2 over 80% or even 100%, and which also means that you should sedate and paralyze the patients in order to ensure adequate oxygenation. So it's very common for us here in Wuhan that after endotracheal intubation, you should heavily sedate the patients and paralyze the patients. So whenever this is the case, I don't believe the volume control and pressure control will make a difference in terms of the effect of the ventilating the patients. So I saw a lot of patients who were ventilated with the volume control mode, and some other patients ventilated with pressure control mode. However, majority of them are, I think, the tidal volume with a tidal volume of 6 to 8 mils per kilo. And in terms of PEEP, I should admit that when I first saw the patients, I often set PEEP of 15 or even 20, close to 20. But however, right now, I would rather prefer a lower PEEP. I just mentioned that 5 to 10, if possible. What else? Tidal volume, PEEP, and frequency. The respiratory rate. I would say that here in Wuhan, we have a lot of patients with severe hypercapnia, which has not been observed in other provinces in China and in Italy right now. I have discussed with my colleagues in other provinces and in Italy, and they have not observed such a severe hypercapnia with PCO2 up to 100, all the way up to 100, or even higher. And I think the patients they treated were in the early stage of respiratory failure, which means they intubated them quite earlier. And another clue to this is that the FiO2, initial FiO2 setting was 40 to 50%, which is never the case here in Wuhan. So whenever you have the patients with severe hypercapnia, the respiratory rate is always 30 something, 35, or even higher. With minute ventilation, about 12 to 15 liters per minute. Even with this high minute ventilation, these patients are still hypercapnic.
People, here's Flávia. I want to thank our colleagues from China and from Mindray. I will have to leave now. Good luck for everyone.
You too, Flavia. Take care.
Thank you. Thank you so much for your help.
Finish?
Could you please share a little bit of your experience with these patients about the mechanical ventilation, please?
I have one last question. Can you hear me?
Yeah.
Sure.
I know. I think that there is a lot of patients that in some moments we need to be decide about palliative care. When to do this, how to approach the family, because many families hasn't to be in touch with the patient, with their family. So can we handle with this very delicate situation? So many of these patients die and the family doesn't have any contact with them. How are you approach about this?
Well, I would say we have the designated hospitals for patients with COVID-19, in all over China. And in these hospitals, no visitors are allowed. Either the patient is still alive or dead. So you can, the doctors will communicate with the families by phone and to tell them about the updated information about the patients to get the oral consent for any invasive procedures, such as endotracheal intubation, such as ECMO, such as whatever, But however, if the patient died, unfortunately, they will be handled by specific staff with notification to the families. And I don't think the families are allowed to see the patient even after that.
The patient can communicate with his or her family member by phone, by mobile phone, and then to sign some to sign some files and send the photo. To be.
Yep.
In Saudi Arabia, we have a specific policy for this. Any patient that, no matter if coronavirus or not, that is considered as a patient that should not be treated, the doctor, the consultant should go to the family and explain that no matter what we are going to do, the patient has no prognosis, and after appraisal from more than 2 consultants, 3 or 4, the patient was designated for do not resuscitate order. And this should be done by the doctor. In some hospitals, you have some support from social workers and psychologists, and this helps sometimes. But the main responsibility is from the doctor to communicate with the family. Maybe by phone in these days, but anyway, it's the responsibility from the doctor to clarify to the whole family members.
Thanks.
Okay. Only returning to the previous question about the ventilation, we would like to hear from Professor Marcelo about the experience that he already had with this patient and the ventilation. Could you please share with us, Professor?
I think the basic message is that I have the feeling that these patients, they share many physiological aspects that are similar to the patients with swine flu. I mean, severe hypoxemia, which means that it's a kind of disproportional. And this is something that is really striking. So they have very severe hypoxemia, a little bit dissociated from the clinical findings and the mechanical findings, which means that they have relatively good mechanics, but very bad PO2. And so it means that if we don't have patients that were under non-invasive ventilation for a long time, like you had in China at the initial phase, typically these patients, they get intubated with a very good compliance. And then it's very easy, if you have a good compliance, to have a protective ventilation because driving pressure is typically very low. And then, and I think whenever your driving pressure is low, I mean, in some patients we see it below 10, like a recent patient in which driving pressure was 7. You just have to be patient and wait a little bit. And this is why I like to say that we have to think about mechanical ventilation in these patients like a prolonged anesthesia. It's like anesthetizing a patient for abdominal surgery for 3 weeks. And then I share the thoughts that Dr. Dubin was promoting, that initially he was eager to have a kind of higher PEEP use, but later on he's promoting a little bit lower PEEP, something around 10 or even less in some patients. And I believe that I generally agree, but I think we still have to individualize. And I think this is very important. Like in anesthesia, if you, for instance, in anesthesia, if you use, for instance, 4 of PEEP to every patient, we have proven this recently, you are promoting decubitus collapse, which means that in many patients, you are going to promote a very high driving pressure just because you have a stupid atelectasis caused by collapse and gravity. And then in this case, you are doing some harm using such a low PEEP. And then, so in fact, I think we should individualize the PEEP for every patient according to the characteristics. And then we should, we have to use enough PEEP to avoid decubitus collapse. And this PEEP level is varies from patient to patient. We have a recent study using electrical impedance tomography and also esophageal pressure measurements. And then we could show that for patients that they have a high pleural pressure, the PEEP levels that you need to apply during anesthesia are around 14 to 16 centimeters of water. So sometimes the patient needs such a high PEEP just to avoid decubitus atelectasis, not to treat the bad areas of the lung. But some other patients, they need just 6. So you have really to individualize. And in this way, your driving pressure will be almost always below 10 centimeters of water. So I think this is the general principle. And I have been, we are trying to treat our patients either by titrating people with electrical impedance tomography or by using what we call mini titration. Mini titration is kind of, okay, you start from a maximum PEEP that you believe you can handle for this patient, let's say 20. And then you will slowly go down with PEEP, checking what happens with your driving pressure. And then if you reach a point of minimum, after which you start to see an increase in driving pressure again. So let's say you decrease PEEP from 20, 18, 16, 14, 12, and then when you go to 10, you start to see an increase in driving pressure again. Then I stop and I keep the PEEP level at 12. So, and it's interesting that using this approach, we have seen not only an improvement in driving pressure, in CO2 exchange, but also an immediate increase in PO2. And then in average, we had decreased the PEEP level in these patients. I think this is the general.
Marcelo?
Yes?
Good to see you. I'd like to your opinion about the use of one mechanical ventilator for more than 2 or more patients. What do you think about this? It's a surprising idea for me.
Yeah, I think, sorry, I know that we are thinking about all the creative solutions for the lack of resources. But I think this is against everything we know about mechanical ventilation, because okay, you can handle the cross infection. It is possible. You can use a smart circuitry, and then you can avoid cross contamination. But it's absolutely against the principle that you have to individualize mechanical ventilation. So I think we should abolish this idea. I think it doesn't make sense to, for instance, if you put our resources in just fix machines, it would be much better.
If the resume, if you can save one or kill 2, 3, or 4 or multiply, I think this is resume. Yes.
Yeah. Yeah.
Okay, Marcus. Hello.
One more.
Can I ask you another question to Professor Dubin and Youzhong? So how many new cases you are observing the last weeks? You are having new cases, or you are just winning the old ones?
We have new cases. It's only the old one.
Okay, wow. So it's really, the situation got really under control.
Yeah. Yeah, I think.
Wonderful. This is very nice to hear.
We have new imported case. Every day I think about 47 cases today, or all over China. Not in Wuhan, because Wuhan is still locked down. So
I see.
Yeah.
Also, Wuhan is still locked down, and then, but the rest of China not.
No. Yes. So I just read from the newspaper that the CAAC, the China airline, whatever, the authorities, they put a limit on the international flight, daily international flight, to individual, airlines. Only one international flight from a single city daily, allowed daily,
Yeah. And do you have a special feeling about, you cannot keep a city locked down forever, right? So do you have a kind of forecast when you should remove the lockdown? And then we can always think about removing the lockdown, but keeping a very high, like we say, vertical surveillance, in which, okay, any new case is extremely chased, and people do kind of a very deep investigation in each new case, and then you can suspend the lockdown. Yeah. How is your thoughts on this?
The lockdown policy will become invalid on April 8th.
Okay.
And however, I still believe that they will keep. I mean, the government and the CDC staff will maintain a very high vigilance about everyone who come in and who leave the Wuhan or even Hubei province.
So tell me again, the date is 4 of April?
8 of April.
8,
yeah.
8 of April. Okay.
8.
Okay. Oh, we are very curious to see what happens, because here in Brazil there is a big commotion because our very bad orientation of our president. So some people is trying to remove the lockdown right now, which I think is absolutely insane. So it's good to know that you are keeping the lockdown till now, and then just removing 8th of April.
Yeah, it's more than 2 months, 2.5 months.
Absolutely needed. Okay. Thank you for sharing this.
Well, my pleasure.
I would like to, I'm sorry, about mechanical ventilation. Did you establish minimal time in days for mechanical ventilation? And another question, the extubation time, it's a stress hour. Do you have any special care at this point?
Well, I don't think we have a restriction or limit on the duration of mechanical ventilation in our patients. And for weaning from ventilator, I think majority of us do not perform TPs anymore. We just use the CPAP trial or PS, low PS, let's say pressure support of 7 or even 5 centimeters of water, pressure of water. But however, when I intubated the patients, I just did it. I just did it with my face shield, which is okay. So it's nothing so special. I mean, you know, for patients who develop the, you know, respiratory failure, the respiratory failure usually starts on the 2nd week, at the beginning of the 2nd week. And whenever the patient got intubated, we usually spend 2 or 3 weeks, on mechanical ventilation, which means whenever you started to wean the patient from the ventilator, it is, you know, for majority of the patients, it's already 1 month after onset of illness. And so the PCR tests at this stage is usually negative. It's often negative. So it doesn't matter.
And then do you try to be a little bit more conservative in terms of your weaning criteria? So you are a little bit more cautious in terms of prolonging a little bit more to be sure that you have all the parameters okay before doing the weaning? Or you do like every other patient in the ICU?
Well, I think, clinicians are prone to be more conservative when extubating the patients or weaning the patient from the ventilator. I don't know why, but it happens.
Yeah. So the contagious disease.
Yeah, probably.
Yeah.
Probably. Yeah. Yeah. But I think it's a wise procedure, because we don't want to reintubate one patient like this, and then looks like that. Which is your general impression? Because for H1N1, secondary infections were a nightmare, but looks like that for these patients it's not so much. What do you think?
Well, Mrsa pneumonia is very rare, if it happens ever. In patients with COVID-19, I've never seen a single case. I have never seen a single case with Mrsa pneumonia. But however, CRE or carbapenem-resistant Acinetobacter are more common. You can tell that, and for aspergillosis, I saw a couple of cases with, IPA, invasive pulmonary aspergillosis. And I know from the results of the autopsy, I know that a couple of patients, had the IPA, pathological evidence of IPA.
Yeah, even for catheterization. Yeah.
Oh.
We just
Maybe
because it's aspergillosis. No, not aspergillosis, but so yeah.
You mean Candida? You mean Candida?
Yeah, not Candida. So the G test is so high, yeah. But we found the chest X-ray, but we doubt it. But we need to prove.
Maybe because they use steroids or no relationship?
You mean IPA or?
No, the aspergillus.
Yeah, well, I don't know. These patients had the lymphocytopenia. They have their respiratory system. I mean, the infrastructure of the respiratory system has been damaged by the virus. So both of which might contribute to the pulmonary aspergillosis. Not necessarily steroids. Although my personal belief that the corticosteroids might increase the likelihood or the risk.
Okay.
Most of the secondary infection is gram-negative. It's like the Dr. Du said that maybe some CRE and pneumonia. Yeah.
I think there are questions about the how long would you wait to intubate a patient. My experience tells me that delay of intubation, endotracheal intubation might be a risk factor for mortality. So never delay the endotracheal intubation whenever the patient failed NIV or high flow nasal cannula trial. Never delay.
Do you think the NIV is a very dangerous for the the aerosol and so? I don't think that is very so dangerous. No, to be.
Well, it's not safe.
Not safe.
It's not a safe. It's not safer than invasive mechanical ventilation. Although, according to the recommendation or the interim guidance from the WHO, it might be as safer than the old versions of the NIV. I mean, the ventilator, old ventilator, but it would be never as safe as invasive mechanical ventilation.
But in the United States, some doctors told me that they never use NIV for COVID-19. No?
Well, I know that some of the patients have been managed quite well by the NIV or high flow nasal cannula. Yes.
Yes.
To avoid endotracheal intubation. Yes, some of them.
I think it's important to see the ventilatory pattern. I think if I have seen also some cases in which you put on NIV, the respiratory rate is very low. You can observe that the patient is not doing a high tidal volume. And this is the patient in which you can keep it, and maybe it's the only breach you need. Yep. But I think the major problem is in those that you still see a high rate, high tidal volume. This is the typical patient that you should not wait a lot. Do you agree?
Sure, I agree.
Yeah. So I think we should not put a kind of mark like, oh, do not use non-invasive ventilation. I think you can do a trial trial. And if the patient is very calm, very well adapted and not a big effort, it could be a good bridge.
Yeah. And I also think the 2 to 6 hour window of the observation during the NIV trial is so tough. I mean, as recommended by the WHO guidance, it's so tough. So, but anyway, it should not be longer than 1 or 2 days, in my opinion.
You need experienced human resources.
Oh, well, yes, of course.
Yeah.
Okay, all right. It's almost 10 p.m. in China. So more questions, or maybe the last question?
Fiona, there is a question. The professor and Professor Zubin were talking about the mechanical ventilation, and some questions appears here about the weaning, the extubation. What your experience with the high flow nasal cannula or the non-invasive ventilation after the extubation with these patients, because the patients will keep for a longer time in mechanical ventilation, and probably the weaning is more complex than the other patients, right? So what your experience in the extubation?
Well, it has been used. It has been used after the patient was extubated from the ventilator, was weaned from the ventilator and extubated. Both the non-invasive ventilation and the high flow nasal cannula have been used, but not in every patient. Only in selected patients, according to the discretion of the treating physicians. Yeah.
Yeah. Even
and
for some patients, for some patients extubated, and we use a high flow nasal cannula, and we also use the NIV several times, maybe daily, maybe 4 times, 3 times daily. So, and to help the patients to get better oxygenation, even to keep the lung and the alveolar open.
Okay. One more last question. We know that the FDA is not so clear. They're stating about the use of anesthesia machines for these patients to ventilate in ICU, but it's due to the lack of ventilation, mechanical ventilators in the world. Some countries and also Brazil, some hospitals asked us about the use of anesthesia machine to ventilate, to support this patient in an emergency situation. Dr. João Manuel, Dr. Gaccieri, could you please share a little bit more about it?
So is another question for us, right? No, the anesthetic machine has not been used here. I mean, to ventilate patients with COVID-19, not here in Wuhan, and not in any of the cities that I am aware of. I'm not aware of any single case.
This was very common in Italy, right? But not in China.
No.
Yeah, I think the anesthesia machine is capable to ventilate these patients. It's my personal opinion. Okay.
Better than sharing the circuit with just one ventilator.
Oh yes, yes,
Absolutely.
for sure.
Yes, for sure.
Okay, Marcus.
Thank you all for sharing your experience.
Thank you, all the
For
professors.
us, in Caxias do Sul, Hospital Pompeia, to sharing your experience. It was valuable for the management of our patients. Thank you.
Thank you very much.
Thank you, Professor Yu and Professor Yuan.
Thank you.
Thanks. Well, it's our pleasure. It's our pleasure.
Our pleasure. Yeah.
I hope to see you soon.
Yeah.
Okay, I
Take
would
care.
like to say
Take care.
Take care.
thank you.
Bye.
Thank you for everyone.
Bye.
Thanks.
Thank you. Thank you.
Thank you.